Hi everyone, good morning. Thank you very much to OncoAlert for inviting me to share with you some aspects regarding lung cancer pathology and diagnostics. So those are my disclosures. And as we can see in these slides, from the years 2000, we have the opportunity to see a big evolution in the setting of lung cancer. This is not only from the drugs point of view, but also any of these drugs basing on the biomarkers, and the redefinition of lung cancer diagnostics. Is really so exciting to see that after the introduction of the first molecular-based biomarkers like as EGFR on the right side of the slides, you have these really spreads in the evolution. And in the past year, and in particular in 2025 and 2024, one of the hottest big topics that we have in the landscape of lung cancer diagnostic and biomarkers evaluation in lung cancer is summarized in these slides, because many of the knowledge that during the years we have acquired in the landscape of advanced stage non-small cell lung cancer, we was able to transfer also in the early stages. And this starts pointing out our attention on the technologies that we are using, because in 2024 we have a rise of the use of ultra deep digital technologies, and these give us also the opportunity, in example, to move the application of liquid biopsy from only metastatic stage to also early stage. And then another type of acquisition that we have is that one gene does not mean one biomarkers, because as you can see here, we can consider different type of mutation within one genes, like as one specific mutation as one biomarkers, and we have also a deeply discussion on the zooming on one of the section of the DNA that we are analyzing for, like as the exon 20 of EGFR in example, and as you can see here, we have more than 92 insertion in the exon 20 of EGFR. Putting all together this, we are able to redefine that we have the needs to analyze singularly each type of the alteration. And starting with the history of KRAS G12C in non-small cell lung cancer, now we have, in the past year, we have a big hot topic discussion around the possibility to use new drugs in the other type of KRAS alteration, like as KRAS G12D and so on. So this means that now we need to use from lab perspectives technologies that are able to differentiate amongst all these type of alteration and to report singularly this type of alteration. Putting all together this complexity in terms of biomarkers, as you can see in the upper side of these slides, the first two rows of these algorithms are defined by anatomic pathology department, so are defined by the histotype of the tumors that we are considering and the type of biomarkers. And pointing the discussion on what we have previously addressed, like as the needs to differentiate within one gene's different type of alteration, as you can see in the second row, we have now not only MET or EGFR, but we have different chapters of MET, like as mutation, hyperexpression, and EGFRs, like as point mutation, insertion, and so on. All the biomarkers that we need to analyze needs to have a biometrics in which we need to extract cell-free DNA or genomic DNA or RNA, so all the nucleic acids that we need to have in our hands to characterize the presence of these biomarkers. And starting from tissue and considering the growing numbers of biomarkers that we have, tissue is not enough in some cases. And so for this we can complement this type of information by using liquid biopsy, and we know this. But in the past year, what happened is that all this knowledge that we acquired in the advanced stage, so the ability to use ctDNA to characterize the mutation in EGFR, in example, or in the other clinical relevant biomarkers, now moves in the left side of this graph. But if you point your attention in the center part of this graph, you can see that moving from the right side to the left side, the quantity of cell-free DNA, and in particular the quantity of the ctDNA, that is in a small fraction of the entire cell-free DNA, lowering. And so this means that we need to raise the bar of the technologies that we are using for and to detect this type of alteration. And this quantity is strictly related to the morphological characteristics of the tumors that we are considering, and the quantity of cell-free DNA, and in particular of ctDNA in blood streams, is fully connected to the dimension and the disposition of the tumors that we are considering. In the past year, we point the attention on this point, and in collaboration with the R&D department of AstraZeneca, we try to evaluate the performance of liquid biopsy in the early stage lung cancer. And we start to evaluate the performance in terms of EGFR detection. And what we can see is that on the overall we have more or less a 90% of concordance between tissue and liquid biopsy, but with a big difference. We are able to reach the results by using tissue-based biopsy approach in 32 days and in 8 days by using liquid biopsy. So this can be the basis to consider in future and a complementary approaches like suggested by the International Association for the Study of Lung Cancer in the first version of the guidelines of the implementation of liquid biopsy in clinical practice. And one new thing that we have introduced in the past year is the possibility to not only analyze the genomic assets in liquid biopsy, but also the epigenetics facet. So this means that we can combine the information coming from mutation and methylation to verify the presence of the ctDNA also when we are not able to define the presence of a mutation. So the so-called tumor fraction that you can estimate by using different type of strategies, and these strategies is based on the use of methylation assets. If you see in the right side of this graph the point T1, you can see that by using the methylation, you are able to see that there is a fraction of ctDNA shedded in blood streams. But if you see the evolution of the genetic approach of the KRAS G12C in this case, so of the mutation, you have a relative zero presence of this alteration. So this means another time that the keywords for the past year and for the future years will be integration. So we need to integrate information coming from different layers and biological layers. In this slide, you can see an circus, and you can see the level that we have reached right now in terms of analysis, but in particular in terms of the information that we can retrieve from this type of analysis, pulling all together information coming from thousands and thousands of genes. And this information evolves, and you can see that from the movement of these slides, you can collect information coming from DNA level, RNA level, and putting all together and to design this type of graphs in which you have the ability to see simultaneously the information coming from not only DNA level but also from RNA level. And as we have combined it before, in example methylation and mutation, we can combine now methylation, mutation, expression and protein assets in bloodstream, so the so-called 3D biology. Why is it so relevant to integrate information? This is a practical example in which you can see in a patients in which the clinical information are scant and you have only the imaging that are saying that the patient's showing different lesions. But the diagnosing from morphological point of view is so difficult. Starting together in a new biopsy and in a liquid biopsy, analyzing not only the DNA level but also the RNA one, we was able to detect an effusion in ret gene, but in a particular type of fusion, so in a ret with KF5B as a partner of fusions. And so this is really common in non-small cell lung cancer than to the other solid tumors, for which we are able to verify that probably we are in the presence of a non-small cell lung cancer, and working together with a morphomolecular approach, we are able to define that these patients showing an adenocarcinoma. So this means that next generation approaches are not only useful in prediction setting but also in diagnostic one. One of the big questions is the cost to sustain all these activities, but as you can see here, the past year we have shown that maximizing the algorithm with the next generation approaches is not only next generation sequencing but also all the next generation strategies. We are able to use the budgets in really smart way and to improve the quantity of the patients that we are able to serve by using the same budgets if we are able to capitalize all these resources in next generation sequencing strategies respect to single gene testing strategies. The last pillar of the evolution of the past year for sure is our ability to use the new mathematical modeling tool, the new artificial intelligence tool, also in the landscape of predictive molecular pathology, diagnostics, and so on. And as you can see here in the upper part in the left side of these slides, this is so far from a liquid biopsy, but if you push the button on this function, you can see that you can have this type of curves. And these curves seems like as an evolution of ctDNA in blood streams during the time, but this is so simplistic because it's on 2 dimensions. But if you improve your ability to describe on mathematical basis the evolution of the curves of ctDNA during the time, and another time you push the button on these algorithms, you can define in 3 dimensions this situation. And so this is really important, because if you see the intersection between the x-axis and the evolution of this mutation in the times, you can see that you are able to see under the relative zero. So this is a geometrical concept in which when you have one information in your hands, you can have different types of deduction that you can do. But if you have 2 variables, you can have 1 perspective. But if you have 3 variables, you are able to see and to say that there is, in example, a lung cancer mutated for EGFR. So the evolution is so fastly growing, but the newest thing in the past year are not substituting the past information that we have acquired during the years. As you can see in the last part, we need to combine morphological approach with molecular characterization to fully decodify the landscape of our patients and to select the best patients for the best treatments. But the evolution is going also into improve our morphological basis, because as you can see here, many of immunohistochemistry-based biomarkers analysis are coming in clinical practice, and these connected with the new tools like as digital pathologies and AI-assisted tools. And this force is led by the drug conjugates approach that we have now and the bispecific approach antibodies that we have now. And the first example for sure was TROP2, because TROP2 leading the introduction in the clinical trials of a fully integrated digital and AI-assisted tools within a black box to define by using the NMR, the normalized membrane ratio, the possibility to verify the presence of an expression in another way respect to the past. So this way is by using an AI-assisted tools. And we know that this is not only for TROP2, but this is growing for all the other biomarkers, in example like as MET, to combining information coming from different type of the alterations in MET, considering mutation, skipping, translocation, and expression, copy number variation. And MET is the prototype of the complexity in the landscape of the biomarkers evaluation, because it's not important MET itself, but the type of the alteration that we are considering in MET that can work as a different positive predictives or negative predictives biomarkers in relation to any type of drugs or treatments. So another important thing is that in past, in our mind, we have a concept that is the mutual exclusive presence of a mutation respect to another mutation. But as you can see here, when you are in a so complex landscape in which you need to combine different type of the alterations, you don't have this mutual exclusive, because for sure you can have an exon 14 MET skipped patients showing an hyperexpression or a copy number variation of MET genes. So on the overall, what has changed in clinical practice the past year? That the implementation of next generation sequencing increased, and this is related to the increasing number of the biomarkers and the different type of biomarkers that we need to test, that digital pathology and AI-assisted workflow represents a reality in clinical trials, and now we have information to transpose this type of information, and the approaches is also in clinical practice. Liquid biopsy moves not only in advanced stage but also in early stages, and the keywords for the future years will be integration, because we need to integrate all this genomic information with the morphological information in a fully integrated morphomolecular approach to serve better our patients. So thank you very much another time to the OncoAlert for this invitation, and all of you for the attention. Thank you.